So the objectives of today's presentation are to, first of all, define precision health and pharmacogenetics, identify tools and resources available for pharmacogenetic result interpretation, summarize the current and future state of pharmacogenetics at UW Health, and then weigh the implications of pharmacogenomic services on healthcare teams, payers, and patients. So what is precision health? Does anybody have any idea of what that is?
Catering healthcare towards people's genome.
Yeah. So I don't know if anyone could hear that, but Shivani said catering healthcare using someone's genome. So yeah, that's part of it. So what precision healthcare does is it aims to tailor the treatment of an individual using your genes, your behaviors, and your environment. All right, so there's two different parts to this. So precision medicine is a medical model that uses precision healthcare, whereas precision healthcare is a model that combines medicine with public health initiatives that occur outside of the doctor's office to promote healthcare of our patients. Now, today we're going to talk about just one part of precision health, which is that genome or pharmacogenomics. So pharmacogenetics, and I apologize, my slides did not email over very well to this computer. So it's normally on one line. So pharmacogenetics. So there's a difference between pharmacogenomics and pharmacogenetics, and a lot of times people are using those interchangeably, but I wanted to identify what the difference is between the two of those. So pharmacogenomics is the study of how the genes within the genome affect a person's response to drugs, whereas pharmacogenetics is the study of variability in drug response determined by a single gene or maybe multiple similar genes. So pharmacogenomics is really looking at the entire inclusive genome that includes coding and non-coding genes. There's different types of genome sequencing. So whole exome sequencing looks at all the genes in the DNA. Or you can look at a clinical exome, which just looks at genes that are related to a clinical condition. And looking at whole exome sequencing, you can identify variations in the protein coding region of any gene. Whereas whole genome sequencing is the largest genetic test that looks at all of a person's DNA, not just their genes. So like I said, those coding and non-coding regions. So for a little bit of a discussion, in your opinion, is applying pharmacogenetics worth it? Based on what you know about pharmacogenetics, either from the first couple of slides or just what you know in outside knowledge. What are your thoughts? And this is more of a seminar topic, so it's aimed to be more discussionary. So feel free to unmute yourself if you are on WebEx and want to chime in. We'll start in this room.
I think it's worth it if there are protections in place for the patient. Specifically, I know we can't discriminate based on genes, but I know that insurance is still iffy about it and we don't have protections in place. So 100% worth it if we can protect our patients.
Okay. Anyone else have any thoughts?
I think it's like a cost benefit discussion. Like how much is it going to cost the patient? How much is it going to cost the institution? And then is what we find and what we do for the patient going to have long-term benefits?
Yeah, there's Shivani thinking like an admin resident. So the cost benefit approach is one of the big discussions on pharmacogenetics at UW as well. So anybody online want to chime in? I don't know if anyone has their hand raised or anything. We'll move forward. So we're going to walk through an example today to apply pharmacogenetics, learn about how we use pharmacogenetic results and apply it to patient cases. So for a little bit of background, to remind you guys of your, I think, prerequisites for pharmacy school, genetics. So an allele is one of two or more versions of a DNA sequence. The star allele nomenclature is used to, it's numbers and letters that are used to identify a change rather than using that entire cDNA or genome position. So for example, a CYP3A5 star 2 allele nomenclature would identify that there's a genetic variant at the CYP3A5 gene. A haplotype is a group of alleles in an organism that are inherited together from a single parent, whereas a diplotype is the combination of alleles on corresponding chromosomes. Oops, and phenotype fell off of that slide, but a phenotype is the physical manifestation of the genes. So for a little bit of background, that Excel document I sent you guys today, we're going to be working through that. And when you open it up, you're going to see this. It's a disclaimer of how to use the use of the tool and then how to use it as well. So if you have your computers with you, or if you have that document, it is in the invite for today. Again, this is more of a seminar topic, so it's aimed to be more interactive. So you can go ahead and open up that Excel document, and we're going to work through that patient case using that document. As you open it up, I did want to give some credit. So Andrew Keeler is a fourth-year pharmacy student who was on rotation with Kate Hartkopf, and he actually developed this entire pharmacogenetic tool. So that Excel document you open, Andrew Keeler worked his entire rotation to do, and I feel like credit is definitely due to Andrew. So that Excel document you're opening actually compiles a bunch of pharmacogenetic resources into one tool for physicians and pharmacists to use. So there's a couple of pharmacogenetic resources that I wanted to point out that are useful for pharmacists, and if you have a future in pharmacogenetics, you might see these pretty frequently. So the first one I want to point out is the Clinical Pharmacogenetics Implementation Consortium. That's the CPIC consortium, and they have guidelines, generally referred to as CPIC guidelines. And what it really does is addresses barriers to clinical implementation of pharmacogenetics by curating and posting freely available evidence-based detailed gene practice guidelines. PharmGKB or PGKB will also be using in this presentation, but it's an NIH-funded resource that curates knowledge about genetic variation. The important thing about PharmGKB is that it offers a more comprehensive literature review, so you can actually see where they're getting their information from. And then there's the FDA table of pharmacogenetic biomarkers, and that identifies all medications with FDA pharmacogenomic recommendations and provides information on the following: drug exposure and clinical response variability, risk for adverse events, genotype-specific dosing, mechanism of action, trial design, and then additional package information if added. So we'll walk through a patient case. Patient DM is a 52-year-old female who received pharmacogenetic results indicating that they have a variation in their CYP2C19 allele, which can affect the metabolism of certain medications. So the result of their test is that they are diplotype star 2, star 3. So using the Excel document I shared with you, I pose this question to you: what is the phenotype that DM has given her star 2, star 3 diplotype results? I think I got an answer here. I don't know if there's any answers in the chat. Any answers in the chat, Ellie?
No answers in the chat.
Yes, it's a poor metabolizer. So DM is identified as a poor metabolizer using that tool, but you can also use any of those guidelines that I posted for you. So another question, do the results matter? So looking at DM, a little bit more background, past medical history. She has high cholesterol and obesity. She's a current everyday smoker, and her current medications are rosuvastatin 10 milligrams every night. So do these results matter? You guys find anything in your tools? Depends. That's a good answer. What's it depend on? Huh?
What kind of meds she's on,
Yeah,
or meds she would want to start.
that she wants to start. Yeah, so currently she's on rosuvastatin. That is not impacted by her phenotype, but like Megan said, it depends. Because what could she be started on in the future? So that brings me to my next point. So Plavix or clopidogrel is a very commonly affected by genotype. So for a little bit of background, Plavix is prescribed to reduce risk of myocardial infarction and stroke in patients with ACS and or following PCI. And it is the most commonly prescribed antiplatelet drug in North America for those indications. How does it work? So Plavix selectively and irreversibly inhibits the cholinergic P2Y12 receptor, which blocks platelet aggregation for the duration of the platelet's lifespan, which is approximately 10 days. It undergoes hepatic metabolism through biotransformation to form its active metabolite. So 15% of prodrug is available for transformation to an active agent, and then 85% is actually hydrolyzed to inactive forms. So going back to that 15% of prodrug is available for transformation to an active agent point. Plavix undergoes metabolism to a active metabolite using the P450 pathway, and that includes all of these CYP enzymes you see listed here. But in two of the pathways, the CYP2C19 allele plays a role, meaning that the CYP2C19 allele has more effect on the metabolism of Plavix than the other alleles listed, or the other enzymes listed. So there's a ton of population variance in the CYP2C19 allele. So in a study of 2.29 million research participants, 58.3 of the participants had at least one increased function or no function allele for CYP2C19. And furthermore, over 35 star allele haplotypes have been identified and can be categorized into different functional groups, which include normal function, decreased function, and increased function. So what does it mean if they're normal function, increased function, or how do we figure that out? So a normal metabolizer has the presence of two normal function alleles. An intermediate metabolizer has the presence of one normal function and one no function, or the presence of one no function and one increased function. Four metabolizers have the presence of two no function alleles. Rapid metabolizer has the presence of one normal allele, one increased function allele, and then an ultra rapid has the presence of two increased alleles. So going back to DM, now she comes back to the ED and she presented with STEMI recurring PCI. Again, she received that pharmacogenomic testing. We know what her metabolizer type is. So my question for you now is, does that matter? Oh, I don't know how to go back, but does it matter now? Pharmacogenetic results. Yeah, so it's good to know what the patient is at all times during their care, because now we know that Plavix may not be effective for this patient. So I wanted to walk through a little bit of how to use PharmD KB or PGKB So you could go to pharmgkb.org if you wanted to explore along with me, but I also have screenshots here. And when you get to that site, they have the gene-specific information tables. We are particularly interested in CYP2C19 in this case, but you can click into any of them to get more information if you want to explore. And when you click into the CYP2C19 allele, you actually get different types of tables. So it gives you the allele definition table, which you see in that Excel document as well. Allele functionality table that tells you what a poor metabolizer, what an ultra-rapid metabolizer means. And then it actually gives you the diplotype phenotype table. So the CPIC guidelines that I mentioned previously lay out this information in a really nice table, and they do drug-specific guidelines. So if we wanted to know our patient what their metabolizer is, we can use this as well. And that also identifies if they have no function or increased function based on the star allele. So our patient we identified as a poor metabolizer. And what that means based on the CPIC guidelines is that they have significantly reduced clopidogrel active metabolite formation. And their therapeutic recommendation is to avoid clopidogrel if possible and use prasugrel or ticagrelor instead. This evidence was strong enough that the US FDA added a boxed warning in 2016 to prasugrel, indicating that if they have CYP2C19 variation, in particular poor function, that considering the use of another P2Y12 inhibitor is recommended. Like I said, they recommend changing to a different option. There's prasugrel or ticagrelor. So studies actually showed, pharmacogenetic studies showed that in contrast to clopidogrel, CYP2C19 genotype does actually not affect the metabolism of prasugrel and ticagrelor. But there's a little bit of a caveat. Prasugrel and ticagrelor have higher discontinuation rates. If you guys remember, ticagrelor is actually dosed more frequently, it's twice a day. There's a higher risk of bleeding for both of those medications, higher cost compared to clopidogrel in both, and then ticagrelor has a dyspnea-associated side effect, which leads again to that discontinuation, and sometimes patients will convert over to Plavix. So again, discussion, is pharmacogenetics worth it in this case with this patient? Yeah, maybe. So I got a lot of yeses. The thing I want to talk about now is really insurance coverage. So is it worth it to insurance companies? What do you guys think? Probably not. Okay, so now the answer is changing, right? So insurance companies, and why do we think it's not worth it to insurance companies?
More work for little questionable benefit.
That's a good point. It's a really good point. Expand on that. Why do you think it's questionable benefit?
Yes, because we're limited and we don't have a lot of studies available that compare the effects. I mean, we know that it is reasonable to switch them over, but there aren't any good trials out there because obviously this is a newer thing.
Right. And the other thing, if it's questionable benefit, right? Because if our patients fail on something, we just put them on something else, and likely they're failing because they have some sort of pharmacogenetic variant, but do we need to do the testing to figure it out? In this case, maybe, yeah, that might be a good idea because we're putting our patient at risk of, future stroke. But in other cases, when it comes to like antidepressant medications, do we just wait till they fail, or do we want to know pharmacogenetically that they can only take certain medications? It's kind of like an ethics discussion as well. But in terms of insurance coverage, I looked into quotes. And Quartz actually says that CYP2C19 in particular is considered experimental. And then there's also a statin test, which we did not focus on in this presentation, but there's other tests that Quartz identifies as experimental, and they do not cover that for patients. So there is criteria for medical necessity of certain genetic tests, and you can see this document is extremely long. At the very top, it says genetic testing is medically necessary if all of the criteria are met. So really just put this on there, not for you to read, but for you to get a feel for how much criteria they make necessary to actually pay for genetic testing. So Quartz does actually have, so on the positive side, they do have some policies for certain genotype testing, and a lot of these are really focused on an oncology medication. So our oncology pharmacists see a lot of genetic testing, and I don't know, anyone's done an oncology rotation? Yeah, so you might have seen some of these results. So Quartz does pay for the two of these, the NUD15 and then the TMT genotyping. Right. Going to get a little bit of a guess around the room. How much do you think it costs our patients out of pocket to get genotype testing?
10,000.
10,000? Too much? Too much. Any other guess?
10 to 15,000.
10 to 15,000? It's actually a little bit lower, surprisingly. So $250 to $500 patients have to pay out of pocket. Now that's like if they want to get a whole genome sequence, you might be talking 10,000. If they want to get specifically tested for certain genotypes related to medications, it's around that $250 to $500 range. So a little bit of pharmacist integration into the pharmacogenetics program. I called up Mayo Clinic. We actually did a visit there when we were in our first year. So reached out to them to get a little bit more background as to what they do. So they have 3 ambulatory pharmacists and 1 PGY1 resident, or PGY2 resident actually, specialized in pharmacogenomics. And they were in a consult service for Mayo Clinic. So they actually, some of their roles include maintaining Epic Build, maintaining Ask Mayo Expert, which if you have never heard of Ask Mayo Expert, it's an online platform that can actually link into their Epic orders, and certain institutions will pay to use Ask Mayo Expert as well outside of Mayo. And it actually goes through kind of like our protocols that we have here at UW, but recommended practices. And that's not just for pharmacogenetics, that's for any disease you can think of. So it's really a decision support tool. They had tiered implementation when they implemented pharmacogenetics at Mayo Clinic. So they did the train the trainer model. So they identified a couple key expert pharmacists. So those are those 3 ambulatory pharmacists they still have. And then they identified some early adopters within their system that wanted to maybe had a little bit of interest in pharmacogenomics, but didn't really have the background yet. And so those early adopters then went on to train their medication management services, which then went on to train all of their other pharmacists. So all the pharmacists at Mayo Clinic get some sort of pharmacogenetic training on onboarding, mainly to understand what certain alleles mean and what the tools are that you can use to interpret results. They do have a CE program. It's a 16-hour CE program accredited by ACPE and the AMA, and it's solely on pharmacogenomics, which is a pretty interesting course that they get to run. Has anyone heard of the All of Us research program? Okay, I see some nods. I see some head shaking no too. For the 2 nods, what is the All of Us research program to your knowledge?
Trying to sequence or collect information from populations so that they can build a database, and we have the option of signing up for this here in Wisconsin.
Yeah.
Is my understanding.
Yeah, it's a pretty good synopsis. So I'm clicking on my computer and that's not the computer I'm using. So the All of Us research program is an NIH funded research program. The program goal is to connect the genetic and health data from 1 million volunteers living within the United States to accelerate research and create that database that you were talking about that may improve health in the future. So genetic data, the way that they collect that information is it's through blood or saliva samples that are analyzed using genotyping and genome sequencing. And then health data, actually, when you sign up and agree to be a participant in this research, you actually agree to submit surveys about your lifestyle and your environment, and periodic surveys about any new diagnoses, any new disease states, et cetera. Participants have the optional choice to give them access to their EHR as well, just making it easier so they don't have to submit that survey-wise. But really interesting that that there are people within Wisconsin partaking in this as well. And they also may share data using their wearable device. I thought that was kind of cool. So if you use like your Apple Watch, you can share it to the NIH and they'll follow you and try to track your genome to see, do your genes affect, the way that your physiology works. So a little bit of a timeline or background on the All of Us campaign. So the All of Us campaign in January 2015, the program was announced during Obama's State of the Union address. December 2016, the 21st Century Cures Act passed and authorized $1.5 billion over 10 years for the All of Us research program. In May 2018, they actually finally opened up national enrollment. And then soon, pharmacogenetic results will be released. So we received indication that pharmacogenomic results will be released to patients. We do have patients here within UW Health, and basically they'll be told if they're their metabolizer, what kind of metabolizer they are, but not necessarily anything more. So we're going to get quite a few questions possibly in the future about what those results mean. As of October 5th, 2022, there were over 372,000 participants enrolled in the All of Us campaign. So not yet 1 million, but they're getting there. So all of us at UW Health. Our expected population at UW Health is about 4,600 patients medically cloned within UW actually partook in the All of Us campaign. If they will all have results, that's unsure, but 90 to 95% of people have some sort of a variation within their genome that affect pharmacokinetic results to medication. So we're expecting at least 90% of patients will have some sort of result. If they'll reach out or not is also a question. So 30 to 40% of the patients will have actionable results. So things that we need to actually change. They're on a medication that they shouldn't be. And the additional 60% of patients may or may not reach out just to understand what their results mean. So all of Us results actually only test for certain alleles. So it's not a ton of alleles, or the results that they'll share will be for certain alleles. So in particular, they'll share results on the CYP2C19 allele, the DPYD enzyme, the G6PD enzyme, NUD15, the statin SLCO1B1, and the TMT, TPMT, and the UGT1A1 alleles. So that obviously is not inclusive of our entire genome. That is inclusive of what you have in that Excel document. So that Excel document actually does not have the entire genome. It was particularly developed just for the All of Us campaign results that our patients will receive. So UW current states, there's no protocols in place for inpatient or outpatient genetic panels outside of oncology. So there's some areas of opportunity identified. If you can even look within that Excel document, you can recognize that there are certain certain practices that these medications might be helpful in. So neurology, cardiology, psychiatry, and then primary care, of course. There's no standard location for documenting any genome alleles or phenotype changes in the EHR. So current state, utilizing the allergy section might be an option, maybe using the problem list. Those are the types of things we're talking through right now. If we put it in the allergy, it's not necessarily an allergy, but there's some options within the EHR to document. So some future plans. What are we going to do with the results? So the results or the methods done in the research setting are not validated to make clinical decisions. So that's important to remember. So patients who get some sort of pharmacogenetic result actually will need to get a CLIA certified lab test done in order to confirm these results. So just because they got their genome sequenced by the All of Us campaign, and it said they have a phenotype of a CYP2C19 core metabolizer, we won't take that as fact, and we actually are going to require them to get an additional test to verify the results. So again, that's money out of pocket because insurance companies aren't covering these tests like we had identified. So some proposed primary care workflows. I'm just putting this up there. I'm not going to walk through it completely. But there are some pharmacy steps within there. On the ambulatory side, our pharmacists are actually going to be involved in these results. So when a patient does inquire about their All of Us campaign results, the RN is going to trigger a question over to the pharmacist, and the pharmacist will actually be reviewing their phenotype using that tool that I sent you to better understand what changes we need to make within this patient's care. So EPIC, I did mention that we don't really have a place to document pharmacogenomics in our EPIC, but there are pharmacogenomic modules, and Jess told me that this is coming soon. So within the pharmacogenetic modules, you can actually put their pharmacogenomic results, and it will link to medications. So when a medication is ordered for that patient, it will say that they're a core metabolizer. What does that mean is what we as pharmacists would have to follow up with. So future implications in the EHR. So cloud storage of that pharmacogenomic data, the genome's humongous. As it grows and grows, we're going to find, or as that study grows and grows, we're going to find out more and more about new genes and how they're affecting medications. Having cloud storage of that information and then also sharing that information with other organizations with the same EHR is a future step that we could take to better understand the results that we receive. Actually documenting the haplotype or a diplotype within their EHR and where we document it so that their primary care provider sees it, but then also when they're transitioned to an inpatient setting that we understand and see it as well as a future step. And then integration with current clinical guidelines and genetic variation information. So we have tons of protocols here at UW, updating those protocols as needed to address pharmacogenetic variants, maybe a future step. So there are best practice alerts that can be used, and that will flag, like I said, when the medication is ordered for a patient, that they might have some sort of a variant in. So there's critical ones. So maybe that's that core metabolizer that you can't use prostaglandin. And then we can do some sort of intermediate BPA that maybe it's just track therapy or monitor therapy. Having actionable BPAs is a really important thing as well. So something that actually links directly to the guidelines is something that would need to be developed within our EHR or to that tool, that link directly to that tool, so that results can really be understood. So for discussion, should we document All of Us data in a patient's chart at UW? What are your thoughts? I see some nods, yes.
So currently, if you're enrolled in all of us, it shows up as research participant, like on the sidebars. If you click, it actually shows that they're that. So if that's already there in Epic, I think yes.
Yeah. From ethical standpoint, I would say yes. But given that we are not technically supposed to act on research results of a patient, there's some discussion about, do we document it, and then how serious do we take it? And then how do we recognize if a patient has been verified by that CLIA test? So I put up this with the QR code if you want to sign up for the All of Us campaign. We talked about it kind of a lot. If you want to submit your data, submit your genome, that's here for you. I want to say a special thank you to Kate. And then I did want to spend the last couple of minutes having additional discussion on pharmacogenetics and what it means in the healthcare system. Yeah, I will open it up. Does anybody have any questions, first of all?